the case in the past. You can see. Okay, I got that. That recording is in progress. So this is a paper by Nick Kilmunci 1.5 years before in Blood Advances regarding the value of MRD negativity, not only in the relapsed refractory, but also in the newly diagnosed. I have put there the results in the relapsed refractory myeloma, where you can see that if a patient achieves an MRD negativity with your treatment, the 3-year probability of progression-free survival goes up to 72% versus only 23.5% and the median of 13.8 months if the patient cannot achieve an MRD negativity, which is the majority of the cases with the treatments that we use now in the relapsed refractory setting. You see again that this is true for overall survival. So this is both for the newly diagnosed and the relapsed refractory multiple myeloma. You see in more than 1,000 patients that if you achieve in the relapsed refractory setting an MRD negativity, you have a hazard ratio of 0 to 28 for overall survival advantage. And you can see that achieving MRD negativity in the relapsed refractory myeloma offers you more survival advantage compared to the newly diagnosed patients, transplant eligible or transplant ineligible, suggesting how important it is if we are able to achieve an MRD negativity in this setting. And you can see that the 3-year probability of overall survival in a patient who achieves an MRD negativity is 86.4% versus 58% of a patient who cannot achieve an MRD negativity, and the median survival for this patient is 42 months. The problem is that lenalidomide and increasingly daratumumab are being used widely in the frontline therapy based on the 2 pivotal studies. I think that the Maya is one of the most important study because now we expect a median PFS of around 5 years, which is something extremely good for the patients who are elderly and cannot be able to have an autologous transplantation. And also the SWOG study that was published previously and offered to VRD, gave to VRD the license for first-line therapy with a median PFS of something less than 4 years versus 30 months for the lenalidomide and dexamethasone. I think that these 2 studies have produced the 2 regimens that are used more and more in the Western countries and the US, VRD and RRT for the patients who are not eligible for transplant, while, as I know, Velcade with cyclophosphamide and dexamethasone seems to be the standard of care in South Africa. The European Societies of Clinical Oncology and the Hematology Association published last year the recommendation for for the treatment of myeloma. Here you see what we recommend for the first relapsed based on the first-line treatment that according to these guidelines were the VRD and the DARA-RD that I previously mentioned, and also DARA-VTD or DARA-VMP, DARA-VTD for the patients who are eligible for transplant. VRD also is a treatment that is licensed in European countries and of course in the US for treatment in the transplant eligible patients as induction treatment. But if you have here VCD, then the lenalidomide sensitive patients, if of course they had received VRD, but if they haven't received lenalidomide and you have PCD there, then all these therapies can be given to your patients. And I believe that we talk mainly for lenalidomide-based regimens like carfilzomib lendex, daratumumab lendex, ixazomib lendex, and elotuzumab lendex, depending on what you have in your country. Lenalidomide refractoriness is not a real problem to you for the second-line therapy, but it may be as third or fourth line. And this is an extremely difficult situation because if you have a lenalidomide refractory patients, then you have very, very few options that have been licensed, which is the combination of pomalidomide with Velcade and dexamethasone if the patient is not Velcade refractory. The combinations of carfilzomib with the monoclonal antibodies targeting CD38, daratumab, and isatuximab, ISA-KD and DARA-KD, and also selinexor with Velcade and dexamethasone has been recently approved in the United States. If you have bortezomib-sensitive patients, of course, you have all these options available. But if the patient is lenalidomide and bortezomib refractory, then only carfilzomib combinations with DARA or isatuximab are the best treatment. I don't want to discuss a lot about the second-line options after DARA-RD or DARA-VTT, but we can discuss a little bit about DARA-RD because this is also an option in the first relapse for you or the third relapse, and then possibly when you give both DARA and lenalidomide, you can imagine that you end up with a patient who is lenalidomide refractory, but also DARA refractory. This is why you are not going to see here any level of evidence, in contrast to the previous part of the slide, because we don't have any evidence for any combination that has been licensed for DARA refractoriness. However, if a patient is lenalidomide refractory and because the patient has been exposed or is refractory to DARA, then the combination based on DARA or isatuximab cannot be given to this patient. So the combinations of POM-VD or KD or selinexor VD may be given to such a patient. You understand that these combinations are much weaker regarding efficacy compared to the initial DARA-RD. But this is also a problem that you may have at later relapses. If we talk about lenalidomide-based studies, because this is important for you as you don't give, in the majority of the cases, lenalidomide upfront, then the lenalidomide-based regimen at second line are important for you. So the combination of carfilzomib, DARA, ixazomib, or elotuzumab are of great importance. You can see here that regarding the PFS, only the Pollux study seems to have a great advantage compared to the others. And also we have in the Aspire and elotuzumab, we have also overall survival benefit from these studies. Here you see the four regimens together compared to lenalidomide and dexamethasone, where you can recognize, first of all, that DARA-RD gave the best response in this setting with 1 till 3 prior lines of therapy with a median PFS of 44.5 months. Of course, no patient had been treated with DARA before, and 17.5 months with lenalidomide and dexamethasone. I have put all these four curves together for two reasons. One is to compare the hazard ratios that you can see here, 0.44, 0 compared to all the others that are very near, 0.69, 0.70, or 0.74, but also to see the differences in the control arm, the RD. So you can see that in the Aspire and the Pollux study, the RD is doing the same, 17.6, 17.5 months. But when we go to Eloquent study and the Tourmaline study, you can see that the median of the control group is much lower. For example, here is only 14.7 months. So you understand that we have almost 3 months of difference between the two studies. And this is a placebo-controlled trial also. If someone wants to know why this happened, I can tell you that this is possibly because the treatment of the patient is given either at biochemical or clinical relapse, and the ratio between biochemical and clinical relapses is producing these differences. We've seen, for example, within the Greek myeloma study group, we had a study published in Annals of Hematology some years before that at second line, if someone is treated with Lendex at biochemical relapse, the median PFS is 24 months. If the patient is treated in clinical relapse, this goes down to 13 months. So you understand that this difference between 14 and 18 months in the control arm is mainly probably because of the different balance between biochemical and clinical relapses. You see here again the 14.7 with the 17.6 months between the combination of carfilzomib with lendex versus ixazomib lendex, and someone can say, okay, if you see only the median PFS 26.3 months, 20.6 months, KRD is better, but you can recognize that the hazard ratio because of the control arm is much better. And this is what I previously mentioned. I had this slide here. The median PFS for lenalidomide and dexamethasone as second line for biochemical relapses is 24 months versus 13.2 months for those who are receiving the combination in clinical relapse, and the median for the total is 19 months. In this 207 consecutive patients treated within the Greek myeloma study group centers with lendex as second line therapy. So you can see that this 7 months of difference, which of course reflects also the median of 6 months that we know that the biochemical relapse needs in order to go to clinical relapse, possibly this is the reason of the differences that we've seen previously. Another important issue is the real-world data that we see in several studies that many times cannot reflect what we see in the big papers of the phase 3 studies. Regarding ixazomib, and I want to mention that not only because Takeda is sponsoring my presence with you, but also because I think it is extremely important to see that all these studies shows a median PFS which is very near or even higher to the 20.6 months of the median PFS of the Tourmaline MM1 study that IRD offers to your patients. And this is the highest number of patients that has been given IRD, 564, results from 3 different registries, the INSIGHT registry, which is a global prospective study, the UVIA, which is a European retrospective longitudinal cohort study, and the REMIX, which is a French both prospective and retrospective study. And you can see from this 564 patients at the median age of 68 years of age who received IRD, 20% of them aged more than 75 years. You can see that the response rate is totally similar to what you expect for a response rate, 65%, at the second line, 70%. And if you can see the median PFS for the whole cohort is 19.9 months, 20.4 is the Tourmaline. For the second line, 21.7. And if you see the frail and the non-frail, again, the difference is in favor of non-frail with 21.6 months versus 11.8 for the frailty. So in general, you can see that from a huge data set with IXA, lendex, you expect in the real world what you have seen in the New England Journal of Medicine paper with low dose reduction and discontinuation. IRD is a rather safe combination. In our hands also, I think that we reduce the dose of ixazomib only because of diarrhea and very infrequently because of peripheral neuropathy. So I'm coming back to one of the most unmet needs in the relapsed refractory multiple myeloma therapy, which is the lenalidomide refractoriness. You don't have it at second line, but you have it at third or fourth line of therapy. And I think that this is important for the definition of lenalidomide refractoriness. Also, you have it at second line for those who receive lenalidomide maintenance after transplant. So I think the question is it defined as progression at any dose level of lenalidomide? Is it the same if the patient progresses while on lenalidomide maintenance at 10 or 15 milligram or on full dose of 25 milligram? Is it the same if a patient progresses after 12 months of lenalidomide maintenance or after 5 years of lenalidomide maintenance? Is there any difference if there is biochemical versus clinical relapses? I think all these are important questions. And in order to give this answer, my colleague Stathis Kastridis published 2 years before in Blood Advances what happened with pomalidomide and dexamethasone salvage therapy in those who were previously treated with lenalidomide as the last prior therapy. And you can see here that if you give 5 to 15 milligram of lenalidomide versus 25 milligram of lenalidomide as last lenalidomide dose, and you treat your patient with pomalidomide and dexamethasone, you can see that there is no difference. The median PFS is exactly the same, 5 months, and the median overall survival around 1 year. So if you treat your patient or you salvage your patient with POM-DEX, the dose of lenalidomide that made the patient to be refractory to lenalidomide plays no role. But what plays a significant role is the time on lenalidomide treatment before the refractoriness of the patient to lenalidomide. So see what happened there if the patient received lenalidomide, for example, as maintenance therapy, and progressed within 12 months of lenalidomide treatment or within 18 months. You can see here that if a patient progressed on lenalidomide and received lenalidomide for less than 12 months, the median PFS is 3.2 months only versus 7.8 if the patient progresses well on lenalidomide for more than a year. And the overall survival is 8 versus 16.5 months, so half the overall survival compared to lenalidomide refractoriness within 12 months of treatment. If we put the cutoff to 18 months, then you can say that the overall survival is even higher if the patient progressed on lenalidomide having received the treatment for more than 18 months, so this was 27 months versus 9 months for those who progressed on lenalidomide and received lenalidomide for less than 18 months. So I think that from this paper, it is obvious that the duration of lenalidomide therapy is more important compared to the dose when the patient becomes refractory to lenalidomide. So refractoriness to lenalidomide is a real problem, as treatments like KD, carfilzomib, and dexamethasone, or even therapies based on daratumumab, like daratumumab, Velcade, and dexamethasone, offers very low PFS of 8.6 and 7.8 months, respectively, suggesting that lenalidomide refractoriness is a real challenge. The combination of pomalidomide with Velcade and dexamethasone offers a rather cheap, due to the generic of Velcade, and very soon we are going to have generic pomalidomide, a cheap combination that offer a median PFS which is not dramatically high, 9.5 months for 1 till 3 prior lines of therapy. But if we talk for second-line therapy, this 9.5 months goes up to the 17 months. So for second-line therapy, it is important. But after the second line, you can see that even POM-VD offers similar to the previous. You see 8.6, 7.8, 9.5, nothing extremely important. But in this specific combination, the second-line therapy is important. The best results in this setting are given by the combination of daratumumab with the other proteasome inhibitor, carfilzomib. You can see here the study design of the CANDOR. You know, of course, the CANDOR study, where you can see that the median PFS is 28.6 months versus 15.2 for carfilzomib and dexamethasone, which is what you have seen also in the main study comparing KD with Velcade and dexamethasone. And these 28.6 months are extremely important. When you put isatuximab instead of daratumumab, you have similar results with the median PFS, which is very high. And if we talk about lenalidomide refractoriness with a PI combination with a monoclonal antibody. You can appreciate with the Castor, the DARA VD offers you only 7.8 months. For the Cantor, the DARA KD offers you 28.6 months. And with isatuximab KD, this may be near to the 28 to 30 months because the results have not been announced yet. So you can see here that although in the Castor, the PFS hazard ratio is much lower in favor of DARA VT, but because of the weak control arm, the DARA KD and the ISA KD seems to date to give the best results in lenalidomide refractory patients. If we go to data on lenalidomide refractory patients with pomalidomide-based treatments and not with carfilzomib, who have their several results. The POMVD that I previously mentioned to you that gives a median PFS of 9.5 months. The results are not much higher if in pomalidomide, instead of Velcade, you add a monoclonal antibody targeting CD38. So it's only 11.4 months for Icaria study and 9.9 months for Apollo study. Here you have not to forget that the median lines of therapy for the Icaria and the Apollo study is 3 and 2, respectively, compared to the Candor study, where the majority of the patients received treatment as second-line therapy. But even elotuzumab Pomdex gives you 10.2 months, suggesting that, yes, carfilzomib-based combinations with monoclonal antibodies offers very good results in the lenalidomide refractoriness, but pomalidomide-based therapies, even with bortezomib or monoclonal antibodies, isatuximab, daratumumab, or elotuzumab, offers rather poor results. One important issue is the role of autologous transplantation at first relapse. I think that this is very also very near to your pragmacy because we have autologous transplantation. You have a lot of centers that offer autologous transplantation. So what we've seen here is that we do have an advantage of autologous transplantation, especially if you compare it with cyclophosphamide, like in this MRC study, that of course now it cannot be a good control arm, or you have different transplant, different other control arms in transplant patients. But I think that the ESMO EHA guidelines suggest that the second-line autologous transplant is a logical approach for patients who relapse after primary therapy that includes an autologous transplant followed by lenalidomide maintenance and had an initial remission duration of at least 36 months. If you have not given lenalidomide maintenance, then even an initial remission duration of 24 months may be enough in order to think of a second transplant. And the use of reinduction is a matter of debate, as there is no prospective study on this issue. Retrospective studies suggest that the use of reinduction does not offer survival benefit in salvage autologous transplant. However, I have to say that in our center, if we want to give a second transplant at the time of relapse, then we don't give, if we have given VCT, for example, we prefer to go for KRT as induction for 4 cycles and then to go to the transplant, or if the patient does not want to come every 2 times per week in the center, we give IRD, like what they are doing in the French study with IRD. For pentarefractory patient, which is also an important, or triple class refractory patients, the only therapies that have been licensed today are the belantamab mafodotin, selinexor, and now we have the 2 CAR-T products. I have just put one slide here for you just to show you the median PFS, which is with one drug like belantamab mafodotin is very low, is around 3 months. But with ide-cel, which is the approved in both EMA and FDA, going up to 8.8 months, the median PFS, with a median overall survival of 19 months. And for the cilta-cel that now has been approved by FDA, the median duration, the median PFS seems to be more than 14 months now. And I think that this shows you the CAR-T cells probably gives the best results in this setting. And for eligible patients, I definitely support the use of ide-cel or cilta-cel, either if you have as a commercial product or in clinical trials. So in order to have some time for discussion, I think that patients who receive second-line therapy, if they had received the bortezomib-based therapy upfront, like VCT, without lenalidomide, of course, or daratumumab, then they could receive an RD-based regimen. This gives the best results. KRD, DAR-RD, IRD, or LRD. DAR-RD, we have to say, that provides the best PFS for these patients. KRD and LRD show the overall survival over RD. I expect that DAR-RD is going to show the same. IRD, on the other hand, has given very good results in the real-world setting and also in frail and high-risk patients. Patients who are refractory to lenalidomide upfront could receive either a combo with anti-CD38 monoclonal antibody plus carfilzomib dexamethasone, or the combination of pomalidomide, Velcade, and dexamethasone, or Dara-VD with lower efficacy. Venetoclax is a drug that gives some good results in patients with translocation 11-14, but I think that AbbVie has decided not to continue its development in multiple myeloma. And regarding the patients at third and subsequent lines of treatment, for patients who have been exposed or are refractory to both bortezomib and lenalidomide, combinations of carfilzomib or pomalidomide with monoclonal antibodies like isatuximab, daratumumab, and elotuzumab can be given. For triple-class refractory patients, selinexor with dexa or belantamab mafodotin have been recommended. However, due to the extremely good results of the CAR-T studies, the ide-cel and the cilta-cel have been licensed for treatment in triple-class refractory patients. And now we know that the CAR-Ts and the BiTEs going to even to first-line therapies for patients who are both eligible for transplant or non-eligible for transplant, to see what is going to be the real role of these important immunotherapies in the treatment of myeloma. And with that, I think that I have managed to complete my difficult task to talk in half an hour for the treatment of relapsed refractory myeloma and the challenges that we have. And with the main building of the University of Athens, I would like to thank you for your attention, and I'm happy to have questions.
Well, thank you very much, Evangelos. That was quite a marathon session. I'm sure that I'm not the only one who's envious of your budget, that you can offer your patients such a broad range of therapies. I think it's absolutely fantastic. And you know, a lot of people don't remember, but it's not so long ago that we offered people melphalan and prednisone, and that was all they had, and then the advent of the autologous transplant. But you raise a very important question that I think that we face here with limited options, and that is, and I've had this discussion with many of my colleagues, do you use your best therapy first, recognizing then that once the patient fails that, what will you use? So, you know, if you don't have access to carfilzomib, pomalidomide, and daratumumab, what do you use in your induction therapy? So in our practice, we tend to follow the line of getting the best response up front, and then putting the patient, so we use the BRD as an induction regimen, and then put our patients on maintenance lenalidomide once the autologous transplant has been performed. But of course, the question then is, how do you salvage those patients? And do you, I suppose the first part of that question is, do you continue the maintenance indefinitely, or do you stop at 2 years if the patient is still in remission? Maybe let's start with that question.
Yeah, okay. First of all, regarding the first part of your initial questions, which is if we give the best therapy that we have in first line, I would say yes, for two reasons. If the patient is eligible for transplant, then we may be able to achieve an MRD negativity that this can offer a prolonged PFS with very good quality of life. I'm not totally sure that if we don't achieve an MRD negativity, we will be able to give an extremely prolonged PFS, but definitely it's going to be long. And I have seen a lot of patients with so good quality of life. For example, if you give DARA VRT induction, but I know that it is extremely expensive combination, but this is more or less what the majority of the Greek physicians are using, plus autologous transplant, and with lenalidomide maintenance, we expect to have a median PFS of more than 6 or 7 years, and the quality of life is extremely good. And that is why I believe that even in the elderly population with DARA-RT, if the elderly patients have a standard risk myeloma, I can tell you that the DARA-RT regimen is offering more than 5 or 6 years, even in patients at the age of 80, because it is extremely safe. And if we avoid the infections, which is the main problem, especially in the elderly, frail patients, it is a very good and safe combination. So yes, I would prefer to give the best drugs that I have at first line without having strong evidence that this can offer an overall survival advantage compared to specific consecutive therapies. For example, if I compare VRD with DARA-KD and I don't give DARA first, for example, so I will not have these answers, but definitely the PFS is prolonged, the first PFS, and the quality of life is very high. Now coming to the second question, for example, I know that you give mainly VCD, is it correct, in the South Africa, Velcade with cyclophosphamide before transplant, or no, or it is VRD in the major centers?
I would say that we are in the process of shifting, that with the advent of genericized the bortezomib and lenalidomide, the option to use both agents in the induction is becoming more popular.
Okay, so if VRD is the standard, then you follow exactly what the majority of the countries, the Western countries, are doing. Okay, very few countries have registered DARA upfront. I mean, even very rich countries, they don't give DARA upfront. France, for example, they don't give DARA upfront, maybe for cycles with VTD, but they don't give DARA VRD. So, and we don't know definitely that DARA VRD is much better than VRD in terms of PFS, and in this specific combination, I think it would be extremely important to know the PFS too. For example, if you give DARA VRD versus VRD, and you continue with DARA R maintenance versus R maintenance in the VRD, then in this setting, it would be extremely important to know the PFS too, where what we are going to do to someone who is receiving DARA VRD plus DARA R maintenance, for example, how can you salvage even at second line this patient, with which combination based even on carfilzomib, what you are going to give, while in the other cohort you are going to salvage the patient with DARA-KD, that we do know that is an extremely important combination. So then the PFS2 would be very important, and probably we can see that possibly to start with DARA upfront when the second line therapy is going to be so much inferior. If you don't have CAR-Ts, if you don't have BiTEs, then I'm not sure what we are going to face. So if you are giving VRT, I think this is an extremely good treatment. The only option that the only thing that I can tell you is for the high-risk patient is not to give only lenalidomide maintenance if you are able to continue on Velcade at least once every 2 weeks in order to have better results. This is what we have seen. Also, a lot of people here in Greece, they use ixazomib with lenalidomide in order to have an all-oral combination for the maintenance, based also on the data of the maintenance study that in high-risk ixazomib alone has shown good results compared to placebo, of course, but the combination with lenalidomide also is a combo that is used in the US in several centers for maintenance, for those who do not want to come to the hospital even once every 2 weeks. So this is more or less what I would suggest. And for the question for the lenalidomide in standard risk patients, for how long we give it, till let's say 1 year before, we give it continuously till progression, according to the license. Now we are trying to have the MRD negativity. And if the patient is MRD negative with sustained MRD negativity for more than 1 year, not only from the bone marrow, but also have a PET-CT negativity, then we stop. We don't know, of course, this is not based on evidence. We don't know if this is the best to do, but we do believe that we need to have rules in order to stop the treatment at some point and not to continuously have the treatment, the patient under treatment, because this may also produce side effects, as we do know. So for those patients who achieve an MRD negativity, then after the sustained MRD negativity 1 year apart, we stop lenalidomide, and we are going to see the results.
In patients that are in a stringent CR.
Yeah, MRD negativity, which means for us, when the patient achieves a complete response, then we are doing the bone marrow next generation, either sequencing or flow cytometry. And if the patient is in MRD negativity at the level of 10 to the -6, then we are having also a PET-CT. And if this is negative, then we stop.
We have a question from the audience that asking about cross-resistance between the various monoclonal antibodies. And if you failed one, what is the response rate reduced or non-existent in the second, in an alternative? Do you have some?
We don't have a lot of data on that, but I can tell you that first of all, we have some data with rechallenge of daratumumab, for example, with other agents. But even if we have published that in Blood, for example, some years before, with Maria Gavriatopoulou, who is the first author from our center, but I think that this type of studies are not correct, because let's say you have DARA RD, and then the patient progress, and you intensify daratumumab from 1 per month to the standard every week. You intensify the dose, and you add carfilzomib. Then, in order to know exactly what happened, you have to have a randomization there between DARA KD versus KD alone, because you may see the result of KD mainly, and DARA may offer something very little, for example, for the cost of the drug. On the other hand, isatuximab after DARA or DARA after isatuximab, we do know that there are responses of around 30%. But again, we don't have randomized studies, because you change the other drug that comes with the monoclonal antibody, then you may see mainly the effect of the other drug, and at a lower extent, the synergistic effect with the anti-CD38 monoclonal antibody. So from my experience, I cannot say that you can salvage easily a patient who has failed in one monoclonal antibody anti-CD38 with another anti-CD38. So I would love to change the monoclonal antibodies to belantamab mafodotin, that we do have it here in Greece. Now we have a lot of studies with belamaf here, IIS also in first line, we give it. Of course, we have the corneal problems. If we have not had the corneal problems, it could be a fantastic drug because belamaf pom-dex, for example, in lenalidomide and daratumumab previously treated patients in first line give a median PFS of around 2 years, which is also very good, but we have the corneal problems. So I would, or to have an out and see what the BiTEs are doing in this setting.
So stem cells, hematopoietic stem cells express CD38. Have you noticed any difficulty in harvesting patients after direct?
It's more difficult compared to VRD, for example, or to VCD, which of course it's very easy to have the CD34, but we have something around 20 to 25%. Then you increase again the cost because we give Mozobil. With Mozobil, we have no problems. I think it was only one patient that we haven't managed to mobilize, but with Mozobil, we have not had any problem. Otherwise, you may face in 20 to 25% of your patients with DARA upfront a problem based on what you have just mentioned.
In the belantamab use, that the corneal problem, I see from the recommendations that you should space the treatment a little bit further apart in that situation. Do you think that we should be doing that anyway? I mean, maybe after an induction phase, that we should immediately move those patients after, say, the first 3 or 4 doses to those that are responding to a longer interval?
We don't have the data, but I do believe so. And that's why my first line therapies, now I have 3 IIS studies with belantamab, here phase 1/2, belantamab with Lendex that was presented in the last ASH meeting also. We have just now started belantamab Dara Lendex. I think this is going to be a very interesting study with 2 monoclonals. And belantamab with the GSI that increases the BCMA expression plus Lendex. So I have given every 8 weeks, So the dose of belamaf is instead of 2.5 every 3 weeks, which is the monotherapy approved indication. In my first line studies, I have used 3 different doses, 1.4, 1.9, and 2.5 milligram per kilogram. The best dose according to efficacy and safety is the 1.9 milligram per kilogram every 8 weeks. Okay. And with the studies that we now are scheduling with Dara Pom-Dex plus belamaf, we want to see if given the drug every 12 weeks or every 3 months, if it increases a lot the PFS. I think that would be very interesting. For example, you give Dara RD frontline. If you are able to dramatically increase the PFS from 5 years to 7 years, for example, offering 1 belamaf dose every 3 months, for example, without ocular toxicity, that would be great. With the 1.9 every 8 weeks till now, we have not had any grade 2 ocular toxicity every 8 weeks. But of course, it's much more probably in the penta-refractory setting with monotherapy. Probably the efficacy with belamaf alone every, for example, 8 weeks probably will not be so good. But with the combos, I do believe that if you have very good drugs together with belamaf, then if you give it every 8 weeks, so every 2 months or even every 3 months, then I think that you will reduce the corneal toxicity at a level that can be let's say, tolerable for the patients.
Yeah, at the moment it's about 300,000 rand, so that's about $20,000 per dose in South Africa.
Belamaf, yeah.
Is there any benefit to cyclosporin ophthalmic drops?
We haven't seen something like that. The only thing that we have seen is that what we are doing from the allogenic transplant, because I'm also the director of the stem cell transplant. So what we are doing in our acute leukemia patients that they have corneal problems because of graft versus host disease there, is to give the autologous serum there. And we have a company that can produce for us sterile serum of the same patient in order to have drops in the eyes. And we have seen very dramatically, let's say, healing of the corneal lesions. And now I know that because of our results, GSK is doing a study on that, a proper study with autologous serum from the patients in order to not only to heal the lesions, but also to prevent the ocular toxicity and the corneal problems.
Okay. We're not getting enough questions from our audience. I don't know, Andrew, do you want to weigh in here?
Can I just comment? I mean,
just post some questions in the chat room.
David.
Yeah, go ahead.
So just a comment about the use of your best drugs, whatever that is in whatever situation. Obviously, that varies dramatically in state and even from province to province versus private, and on what your insurance capabilities are. But I mean, the other issue is that Mohammed Moti always shows a slide of the attrition rate between various the next level of therapy, and that's quite significant. So I think it really, again, also argues for the use of your best agents, whatever those may be, up front. I'd like to ask Evangelist, the other issue about using the anti-CD38 monoclonal antibodies is the weight-based dosing. You know, that ramps up pretty quickly, and where we practice, we have actually we've got quite a few large people. I mean, I've got one guy who's relapsed refractory myeloma, who weighs circa 200 kilograms. I mean, just the dosing that we need for daratumumab in that situation really makes it unaffordable. So do you take weight into account? I mean, that really doesn't appear in any of the guidelines, obviously, but on sort of on a practical level, what do you do?
According to the PKs of the subcutaneous drug, it seems that it is irrespective. I mean, the dose that is achieved is irrespective of the body weight. And because we are using subcutaneous, it's like the rituximab subcu, so it is a standard dose for everybody. Of course, if you give the intravenous that goes with the kilograms, I mean, 16 milligram per kilogram, of course, then, of course, the money that you need is much higher compared to someone who is 80 kilos, which is more or less the standard. So for the sub-Q, we have the standard fixed dose. And so if someone is huge, let's say, or someone is slim, then we use the same dose.
Yep, that was my question about the... And selinexor, I mean, your experience with selinexor, because we've been able to access that on a compassionate use program, but in our experience with it, it does work in some patients, but the GI and general side effects are very difficult to manage.
You have to start directly. Yeah, we have several patients now, more than 40 with selinexor. We have seen very good combination with carfilzomib, I have to say that, although I know that it is out of label, but what we are doing in some of our patients is based on the result that we've seen in the ASH meeting, in the last ASH meeting, is that we, okay, selinexor with Velcade produced some interesting results, but with carfilzomib, it seems that the combo is very good. Selinexor, you need to treat the patient with a lot of anti-nausea drugs from the beginning. Don't expect the nausea to appear because it is very difficult many times. You have to be from the beginning very aggressive. Is like treatment that you give with ESAP, for example, or with those who treat also solid tumors with platinum-based treatment of the solid tumors. So they need aggressive anti-nausea therapy, devomiting therapy. This is very important. Otherwise, you will experience, GI toxicity that is not tolerable at all by the patient. However, there is a number of patients who respond, and with aggressive anti-vomiting treatment, they are doing well. But I would suggest that if you have, for example, if you have given Velcade up front, and then the patients receive 3 or 4 lines of different therapies, and you end up with selinexor again, combine it with a proteasome inhibitor with Velcade, that probably it's going to be easier because it's generic. The results are much better. Selinexor is not doing very well with the IMIDs, but is doing very good with PIs. May I have just 1 second to put the plug into the computer because I've seen my battery is running low. Only 1 second. Sure. I will be fast. Okay, I'm back.
There was something I wanted to ask earlier, but I've forgotten what it was now. It was about the, pomalidomide still seems to have the same degree of myelosuppressive effect as the lenalidomide in our limited experience, but the diarrhea seems to be much better, and that's much
we don't see diarrhea with pomalidomide. We see some rash, especially in patients who had rash with lenalidomide. So this is something that you have to take into consideration. But yes, myelosuppression is important. Also, we've seen infections with pomalidomide, so never forget to give levofloxacin for the first 3 months of pomalidomide treatment. But definitely, pomalidomide is a drug that can be combined with either a monoclonal antibody, especially with monoclonal antibody, and give some results in cases that you don't have any other alternatives. A cheap combination, of course, with cyclophosphamide. So never give as a doublet POM-TEX, give POM-cyclotex, which is much more efficacious. And definitely, if daratumumab has been given previously, then you can have one of the 2 other monoclonals, Iza or relatuzumab. The combination can be also offer better results compared to POM-TEX alone.
So, do you guys ever do tandem autologous transplants for patients who don't achieve a VGPR with the first autologous transplant?
We don't do that, but we do it for high-risk patients. So almost all high-risk patients are doing 2 transplants, irrespective of their MRD status. Even if they have achieved MRD in the first transplant, we are doing a second one. I don't know if we are doing the correct for those who achieve an MRD negativity. It may be correct because they may lose this MRD negativity very fast. And we have seen also that a lot of high-risk patients, I mean, the lesion 17p with more than 60% of the plasma cells. I have now 38 years of age, young woman with multiple myeloma, the lesion 17p, 90% of the plasma cell. We have given Dara VRT 4 cycles, followed by 2 transplants, a Dara VRT consolidation. We managed to have MRD negativity that was lost within 6 months on Dara R maintenance, Dara VR maintenance with Velcade every 2 weeks also. And now I think that I will not wait for even biochemical relapse or definitely clinical relapse. I will try to find a stadium with CAR-Ts or BiTEs to go for it, because I think that this young patient has no other choice. I've seen some questions that there are in the chat, and one of them was allogenic transplant. If we have some patients, this is a patient that allogenic transplant can be a choice. However, with the CAR-Ts that we have, even with allogenic CAR-Ts, I would go for something like that. The graft versus myeloma effect is very low, and we don't have a good experience on that. I've seen several interesting questions. If you want me to see in the chat and discuss for them. Let's go from the beginning. It was the ESMO EHA guidelines only mention 4 combination in Len refractory. However, there are many more regimens available for refractory patients. The recommendations always discuss data for when we have studies, phase 3 studies. Otherwise, the level of recommendation is very low. And when you have phase 3 studies, you put them into the context. That's why you see only the 4 combinations. I think that we can re-challenge a patient who developed lenalidomide refractoriness after a period of LENA of about 2 years. I agree. We have done it. So if you have stopped lenalidomide after 2 years and then your patient progress after another 1 or 2 years, then definitely you can re-challenge lenalidomide with one of the combinations that you have available with isatuximab or ixazomib or dara or whatever you have. I could go for that. Carfilzomib is registered in the South Africa, as I've seen. We talk about the cross-resistant at the CD38. I think that we talk. Another is question about, can you comment on the preferred dosing schedule of carfilzomib? It depends if you use carfilzomib alone or if you use it in combo. We are using carfilzomib weekly, if this is the question. So if you have a combo where carfilzomib is given like the ASPIRE study with 36 milligram per square meter, then I could go for 52 every week. If you have like KD that you have given 52 twice per week, then you can go with 70 once per week. It depends on what you have. If I use bentamastine, no, we don't use it. Although instead of cyclophosphamide, for example, for patients who have been previously treated with cyclophosphamide, if you want a combo with cyclo, then probably benda is a good option, but we don't use it in Greece. Like also thalidomide, we don't use thalidomide almost at all. Probably we have to do that, for at least for some patients, but we don't use either thal or bendamastine without a good reason, I have to say.
Yeah, I think we wouldn't use it either if we had access to daratumumab and carfilzomib as readily as you do. And bendamustine we use primarily in patients who've got very bad peripheral neuropathies, and we can't re-challenge with bortezomib or thalidomide. So that's the role I think that we would use it. We would use it for. So, Estelle, are there any other matters that you would like to discuss or topics? I can pass back to you.
Well, that was a really amazing high-level discussion. And I think it's important to note, also for all my colleagues in public care in the meeting, that, you know, the things we discussed today are far, far, far above what we are capable of using or have access to in public care. I wondered if Cecile has a specific question or a remark on what she would, you know, how she sees the best treatment that we could aspire to in public care, or if any of our other colleagues at public centers would want to respond. So Cecile, just, you know, speak up when you want to.
Right, yeah. So, I mean, obviously, as Estelle said, we're listening with a little bit of envy and hope when we hear what can be achieved. There is hope in the sense that we all, you in the public sector, know that now for just over a year we've had Velcade, but it's been, as you all know, restricted just to the transplant eligible. And for the non-transplant eligible, we are still in the bad old days of cyclopred and melphalan-pred. And this is for about 70% of patients in the country. But not to paint too dark a picture, the good news from the essential medicine list is that lenalidomide is featuring very high, and there is great promise that len will soon be available to state sector patients. What the restrictions are going to be is not certain, but what Professor Blockman tells me is that it's been looked at for transplant eligible and other, and they're even looking at maintenance. So we'll have to watch the space, but there is hope for the future.
Okay, I think that with Velcade in the transplant eligible patients, you are doing rather well, even with VCD, for example.
Yeah.
And the transplant, but for the elderly patient, yeah, MP or cyclopred is okay. You have to change that.
Yeah, we have to, but I mean, yes, we have to definitely change it, but correctly used cyclone pred can keep an elderly myeloma going longer than many people think. I think
I agree for especially for the frail patients.
Yeah.
Yeah, but for example, you have someone who is 70 years of age, very fit,
Yeah.
then is not
Absolutely.
optimal at all. Yeah, yeah.
Yeah, no, it's certainly an unmet need.
Yeah.
And the fact that they're absolutely restricting that Velcade just to transplant eligible are leaving us with a group that get to transplant. They're not making any provision for maintenance. Our unit can give the patients tandem transplants, which we do, but then we're sometimes stuck with a 50-year-old who's now relapsed after all of this, and there's almost nowhere to go except cyclophosphamide and dexamethasone. But I mean, there is hope, and it looks like at least there is a move towards biologicals for the state patients.
After my two last talks with colleagues in South Africa, I think that it would be a very good opportunity for you to join either the IMWG or the IMS as a group, I mean, not individually.
Yeah.
Because Africa is not, let's say, represented at all in the big societies, or at least with a voice there. And it's not fair. I mean, there are a lot of meetings, myeloma meetings in South America, a lot of meetings in Asia, in countries like India, for example. And we don't have active groups or within IMWG or IMS from South Africa. So even individual, if you come to the US meeting, or where we have the breakfast meeting, or as a group from South Africa, you can ask the IMS or the IMWG to be part of it, participate, let's say, one of the group in each one of the publications, and also to have a voice. And why not, at some point, if you are interested, to organize a big meeting, I mean, like the International Myeloma Workshop in Africa. It is something that I do know that the leaders of the groups, both Nikhil Munshi, who is the president of IMS, and Brian Dury from IMWG, they would love to, because we have discussed several times that Africa is underrepresented in all these big forums, and also let's say a big meeting has to be, let's say, scheduled at least once in Africa, because International Myeloma Workshop has never been in Africa, although it has been in Asia. Now it's going to be in Athens next year after Los Angeles, so you are more welcome to come to our beautiful country. And then the next one is going to be in Rio. So I think it's time that Africa has to be represented, and possibly at some point you can have a meeting in South Africa, that it's such a lovely country. And I do know that a lot of people love to come to your country. Just a suggestion.
It's a wonderful idea. Yeah, sure.
I hope we are going to see you before that time. So I think we must.
Yeah, of course. Of course. I don't talk about myself, but I say that I've seen a lot of questions. I've seen a lot of people who participate in the treatment and in the discussion of myeloma. I think that you definitely deserve to have a more loud voice in these big myeloma organizations.
That sounds great, and I can think of many colleagues who definitely are very well qualified for that in South Africa.
I'm totally sure about that.
I would really like to see you at one of our meetings before then. That would be wonderful.
Yes.
I would love to do it.
Yeah, that'd be great. I think one topic that we didn't have time to discuss today really in depth was, you know, the difference of young African ethnicity patients and how, you know, what would be the best combinations for them, because they truly are beyond the drugs that we have, even Velcade. So that, I don't know if my colleagues in private, if David and Andrew, if you have specific drug combinations for these very, very young myeloma patients who actually do not respond to the typical frontline treatment, but respond to something else. Is there something there that you prefer or not?
Not specifically from my side. I mean, I do say that it's not just young Africans. I mean, we sometimes see just African patients in general who actually present with good genetics, RISS at stage 1, and you can sometimes be struggling even post PRD to get them into any sort of meaningful response. So I think there is something to that. So it's not just young. I think there's more to that story.
So it would be great to have, you know, to think more about that and plan and work around that type of scenario. Yeah. Anyway, David, you look like you want to say something.
Sorry, I was on mute. I know that Theo is quite fond of the sort of total therapy approach in those patients with the VT. We used to use VTD pace, MEL10, and then the BRD pace for the harvest, and then the BRD MEL80 pace for the transplant as the first of a tandem, taking what Angela said earlier as a high-risk patient now, but just by the fact that they'd failed their first-line therapy, and then do a tandem with the second transplant being a MEL200. And we have used that with some effect. But, you know, these patients do badly. I think you also mentioned it earlier, Evangelos, is that if you don't then consolidate with something else, they relapse on maintenance. I mean, they don't last very long.
Yeah, this is the type of treatment that we are using in plasma cell leukemia, as you mentioned, via TPACE, 2 cycles plus 2 autologous transplant. But as you mentioned, these cells have a totally different genetics from the standard myeloma cells, and I believe that the patients progress very quickly. So we haven't managed to find a good drug combination for plasma cell leukemia, extramedullary disease with no bone marrow disease, which is something that we have seen also in some of our patients. So a lot of extramedullary plasmacytomas with no bone marrow infiltration or very low bone marrow infiltration that they don't, let's say, respond to any type of therapies that we give. So I think that these are definitely unmet needs in the treatment of multiple myeloma.
Talking of unmet needs, is there anything promising in the management of amyloid? You know, I think every physician tears their hair out when we see this condition.
I think for amyloid, Velcade plus DARA are the best. I know that it is an expensive combination for you, but this is the best therapy that you can have. DARA VCD, for example, is the best combination for amyloid. So we have seen even in patients with cardiac amyloid, they have some probabilities of living for more than 3 months, for example, that the DARA VCD is doing great, but definitely for renal or other types of amyloid, AL amyloid, the DARA VCD is doing great. And definitely the IMiDs are not doing very well in amyloid patients. But DARA VCD probably is the best treatment that you can give. If you don't have DARA, VCD is also very good treatment. If you don't have cardiac amyloid and you have, for example, renal amyloid or other amyloid infiltration in other parts, VCD is one of the best combos that you can give.
Thank you. Thank you for an excellent talk and for sharing your very broad experience and knowledge. We really appreciate that. Thank you.
Thank you so much, and I am very glad to come either in person, of course, I would love to, but even if you have other web meetings, I would very glad to join you and exchange experience.
Yeah, I mean, Estelle and UCT have put together this fantastic program, and every week they attract 100 delegates. I mean, it is, or attendees. It really is fantastic, and it's a real feather in your cap is that it's sustained, and that's a testament to the hard work done by you and your whole team, Estelle, and bringing us such good speakers every week. So thank you very much.
Thank you, David. Now there's thank yous for me. So thank you to you and Andrew, who so kindly gave of your very precious time and your very extensive knowledge. We look forward, David, to doing a novel upfront therapy under your guidance. So to move into the cellular therapies, thanks to the edge of the private practice. So that is something really, and the vision of those working in it. So we are really very, very blessed. I also say that thank you on behalf of Cecile, my colleague, and on behalf of the university. And thank you, Evangelos. Thank you for giving us such an amazing overview. And we will look back on this talk, and I hope that we can actually have some working group discussions with you at some stage. So let's see, David, what we can do. And then I'm not going to thank everybody today. We can thank Prof. Lowe, who's on holiday and normally chairs so beautifully. And thank you to everybody who's attending today. So, and thank you for Tequila for sponsoring this. So.
Great.
Thank you so much, Estelle. I would be very happy to come to South Africa and or to talk in any other web meeting that you have. Thank you.
Great. Have a great evening. Thank you, everybody.
Thank you. Bye.
Thanks, everyone. Bye.